At 11:13 on a Friday night, a 92-year-old woman came through the emergency department doors on an emergency squad cot. She has late-stage Alzheimer's disease, still talks, just can't tell you what hurts or why she's frightened, or that an hour ago she was found on the floor of her room. Now here's the part I need you to hold on to. This woman does not cry. 92 years, and the people who know her best will tell you she has never been one to cry. 3 days later, she was sobbing. The disease didn't do that. Those 3 days and her experience at this facility did. And that's the reason why we're talking about it. Her daughters wrote a letter about the 72 hours that followed, and today I'm reading you the whole thing, not because this is a family calling out healthcare, but because it's the best reminder I've found in 20 years of why you do this work, exactly who is depending on you, and the lessons that can be learned from this situation. Welcome back to Nursing Matters. I'm Christina, and today's episode is different from what we normally do. Now, before I go any further, I'm not sharing the family's name, the hospital, or the city. That's theirs to keep. Everything else you're about to hear is a true story, exactly as they told it. I also want to say something to the nurses listening before I say anything else, because it matters more than the rest of it. I know what your shift looked like. Somebody called off. You picked up an assignment that was never yours since there was nobody else to call in at 6 a.m. on a weekend. You're carrying patients who each need their own nurse, honestly. Every light in the hallway is red, and the one that's been going on the longest is not one of the sickest, and you know that, and you're triaging it in your head while you're walking. The way you survive a shift like that is by getting efficient. You strip out everything that isn't the task. And that's not a character flaw. It's what a competent nurse does when the system hands them more than one person can carry. This letter is not an attack on that nurse. It's about what falls out of the bag when you're running, and about the 4 or 5 things that can never be allowed to fall out, no matter how fast you're moving. Something is shifting in who actually lands in your beds. The inpatient population keeps getting older, and a growing share of the patients landing on general med-surg floors now arrive with significant cognitive impairment, dementia, delirium, or both. These are patients who cannot participate in their own care. They cannot reliably report pain in words, even when they're still speaking, and they cannot hold on to an explanation for more than a few seconds. The floors receiving them were largely designated for patients who can. Most med-surg units have no dementia-specific pathway, no scheduled protocol for the nonverbal patient, and sitter capacity that evaporates the moment the census climbs. When those 3 gaps line up on a short-staffed weekend, the outcome is remarkably predictable, and it usually gets documented as a combative patient rather than as a system that had no plan. There's a second shift worth naming. Families are more present, more informed, and far more likely to document what they see. That's not a threat. It's the most underused clinical resource on your unit, and the letter I'm about to read is what happens when it gets treated as an interruption instead. Let me read the letter. Dear nurse, I'll tell you who she is because I don't think you ever got the chance to know. She's 92. She's raised children. She's buried a husband. And she's been the strongest person any of us have ever known. For the last several years, she's been disappearing a little more each month into late-stage Alzheimer's disease. She lives in a memory care facility now. On a Friday night, staff found her on the floor of her room. The squad brought her to you at 11:13. I got there at 11:30. There were no rooms. It was the weekend, and we were told it would be at least 8 hours before she could be admitted upstairs. So we waited in the noise and the light with a woman who had no idea where she was, in more pain than she could tell anyone about. The CT scan was conclusive. Her hip was broken. Surgery was strongly recommended. Without it, we were told, she'd spend whatever time she had left in a bed or a wheelchair. My sisters and I listened to the risks and decided to go forward. Sometime after that, a room opened up on the second floor. 3 of you met us there and asked us to wait in the hallway while you moved her to the new bed. We understood. We stepped out. We let you do your job. Then we heard her. My mother has a soft voice now. It's frail. It's been years since she could raise it. Through that door, she was screaming. We opened it. She was completely naked, uncovered in front of everyone, being lifted quickly across to the other bed with a broken hip. Someone was saying, you're okay, while she sobbed. She was not okay. She was 92 years old, naked in a room full of strangers with a broken hip, and nobody covered her. Not with a sheet, not with a towel, not with anything. When you had her in a gown and the second rail up, we came in. She was lying there crying softly with a scowl of pain frozen on her face. People assume a woman with advanced dementia doesn't know. I'm telling you as her daughter, she knows. Her body knows how it was handled, and she was afraid of that room for the rest of her stay. That was the first 4 minutes on your unit. Our trust was gone before we ever put our purses down. She came through the surgery and slept the whole night, and I want to say thank you for that because somebody in that operating room took great care of her. We came back the next day. The same nurses were working. The first thing I noticed was the floor, trash all over it, Band-Aid wrappers, open packaging, the peel-off tabs from the electrodes. It had been there long enough that we counted the pieces and took pictures. When a family thinks about hospital care, we think sanitary, germ-free, clean. That's the whole promise. We can't see your assessments. We can't read your charting. What we can see is the floor. And if yesterday's trash is still next to my mother's bed, we start doing math about everything we can't see. Later that morning, one of you told us she'd start physical therapy and then said, you probably don't want to be here for that if you thought us transferring her was too rough. I know you meant to have that as a joke. I want you to sit with how it landed. We stood in that hallway and asked each other a question I never expected to ask about a nurse. We asked why this person was even doing this job. Here's what we tried to tell you. Our mother sundowns, not sometimes, every single day. Her pain has to stay ahead of her because she can't hold on to the fact that her hip is broken. When the pain comes up and she can't name it, she gets up. She will try to walk on it. You told us you can't do anything without a doctor's signature. That isn't what we were asking. We know you need an order. We were asking that somebody get that order before she needed it, because once her pain is out from under her, this whole situation goes sideways in about 20 minutes. We asked for a sitter. We were told the hospital was full and there were none. We asked if you could wrap her arm to cover the IV because she pulls them out. That's not a maybe, that's what she does. We were told it was the weekend, materials wouldn't come in until Monday, and there was nothing to wrap her arm with. We left that night because we had to. We have families at home. All 3 of us sat in the parking lot first. We were not heard, and our mother was not safe, and we knew it. I got there at 8 the next morning. The IV was on the floor. There was blood all over her robe. The trash from the day before was still there. She was already agitated and already trying to get up on the hip that had been operated on 36 hours earlier. A nurse came in to place a new line, 3 attempts, and then she was called out of the room by one of the nurses from the first night. Before I left that evening, I asked one more time for something for her pain. I explained again, when she gets restless, when she gets antsy, that's her telling you it hurts. She still talks, but the words don't line up with what's wrong anymore. So this is how she says it. You dismissed it. Several hours later, you called. A doctor had approved a pain medication, but she was hysterical and crying, and you weren't sure what to do. I need you to understand what you were describing to me. This woman does not cry. She never has. If she is sobbing, you are very, very late in providing that pain medication. The crying isn't a behavior, it's a symptom. And by the time you're watching it, the window closed hours ago. You called again very late that night to say you have to restrain her because she was trying to hit the nurses. My mother has never hit anyone in her life. She's a 92-year-old woman with a broken hip in a strange room, in the dark, in pain, and every time a stranger comes at her, she does the only thing a frightened body knows how to do. That's not a combative patient. That's a woman who's been in uncontrolled pain for 2 days on a unit that never showed up to take care of somebody like her. After 3 midnights, she had to go back to her facility because 3 days is what the insurance company will pay for. It seems like an awful lot for a woman her age to recover from that quickly. The hospital was not looking at our mother's needs. It was looking at a hip, a bed, and a date. We never needed you to be perfect. We watched you run all weekend. We watched you skip your lunch. Not one of us thinks you're a bad person. We needed a sheet over her body. We needed somebody to tell her what was about to happen, even if she couldn't follow, because a calm voice explaining sounds different from hands arriving. We needed her pain medicine before the pain, not 3 hours after it. We needed 1 strip of gauze around her arm to cover the IV. We needed somebody to believe us when we told you who she is, because we are the only chart that has her whole life in it. None of that costs money. Almost none of it costs time. She won't remember any of it by now. That's the mercy of this disease, and it's the only one it gives. We will remember all of it. Signed, her daughters. Now, I've spent more than 20 years in healthcare, most of it in hiring people who staff floors exactly like this one. Here's why I chose that letter this week instead of a case study or a statistic. Not one of those nurses was hired to be unkind. I would bet everything I own that every one of them interviewed beautifully, went into nursing for the right reasons, and would be horrified to read that letter and recognize themselves in it. That's the part that stays with me. This isn't a story about bad nurses. It's a story about good nurses in task mode on a unit with no plan for the patient in front of them. Task mode is a survival state. It's what your brain does when the workload exceeds what one human being can carry. And it works. It gets you to the end of the shift. What it strips out first is everything that doesn't look like a task. The sheet over the daughter's mother. The sentence before you touch someone, letting them know what you're doing. The 90 seconds with the daughter in the hallway. None of that shows up on a to-do list, so it's the first thing gone. Here's what I've learned watching this industry from the hiring side. Nobody ever gets coached out of task mode. We coach nurses on documentation and throughput and scores. I have never once seen a hospital sit down and say, here's how you catch yourself when you're running, and here's the short list of things you protect no matter what. That's the gap. It isn't a compassion gap. It's a training gap wearing a compassion costume. If you read the letter and felt defensive, I understand it, and I'd ask you to stay with it anyway. Feeling defensive usually means you recognize something. That recognition is the most valuable thing you'll take out of this episode. So let's make this a practical lesson. Here's what I want you carrying into your next shift. First, provide patient-centered care, not task-centered care. The task is how you deliver care. It's not the care. There's a version of everything you did last shift where the patient was at the center of it, and it did not take you 1 minute longer. Second, dignity is a clinical intervention, not a courtesy. Everyone deserves dignity. Covering a patient before you move her takes about 4 seconds. There's a version of that transfer where 3 nurses do identical work in identical time and take a sheet over the body, and it makes a huge difference. Same staffing, same acuity, same clock, completely different memory for that family. When you're cutting corners, cut the ones that cost seconds and give you nothing back. Never cut the 4-second ones that give a human being her body back. Third, narrate before you touch. There's a belief that with advanced dementia, there's no point explaining since they won't follow it. Comprehension isn't the point. Tone is. A frightened brain that can't process language still processes a calm voice arriving before hands do. Hands that arrive with no warning read to the nervous system as an attack, and the body responds, which gets charted 3 days later as combative. Fourth, and this one really sticks with me, stop saying you're okay. It's automatic and it comes from a good place, but telling a frightened person she's fine while her whole body says otherwise is not soothing. It tells her nobody is going to help. Try, I know this hurts, I'm right here, we're almost done. Same 3 seconds, and it's true. Fifth, show empathy to families and take the time to explain why you're doing what you're doing. Most of what families read as neglect is really just silence. One sentence, I'm going to move her now. It's going to hurt for about 10 seconds, and here's why we have to. Turns a family from an obstacle into your ally. Sixth, if your patient is elderly and the family is right there, bring them into the room. Don't send them into the hallway so you can move faster. That daughter knows how to calm her mother in a way you'll never learn from a chart. She knows the words that work and the hand to hold. The family is your best weapon for making sure that patients recover. They're motivated, they cost nothing, and they're there the hours you can't be. Seventh, treat the family as the chart you don't have. Nobody in that hospital had a baseline for that woman. The family did. One question fixes it, and it takes 90 seconds. Tell me the 3 things I most need to know about her that won't be in the chart. Then write the answers down where they can see you're doing it, and say them out loud in handoff. Eighth, get ahead of the predictable instead of reacting to it. A 92-year-old with late-stage dementia, a fresh hip fracture, an unfamiliar room, and a documented daily sundowning pattern is not an unpredictable event. That is one of the most predictable trajectories in geriatric care. The restraint conversation at midnight was decided 18 hours earlier by somebody too busy to get ahead of it, of a known thing. Ninth, escalate constraints instead of absorbing them. When you tell a family you have no sitters and stop there, you personally absorbed a staffing failure that belongs to the organization. You take the blame. Leadership never sees the data, and nothing changes. Say it upward in writing every time. High fall risk dementia patients, no sitter available. Mitigating with this, a documented pattern is the only thing that has ever gotten a unit more resources. And here's the one I want you to keep. Those nurses, whether they realize it or not, broke down a woman's dignity in real time. She can't remember what was said 60 seconds ago. She can't remember her hip is broken. She will never forget how she was treated. It doesn't live in her memory. It lives in her body, in how she flinches, and whether she's afraid the next time someone walks towards her bed. As you develop and grow as a nurse, don't ever forget that. Now let's talk about common mistakes to avoid. Mistake number 1, sending the family into a hallway by default. It feels faster and more professional, and with a cognitively impaired patient, it's usually the opposite. You just removed the one person who can bring that patient's heart rate down. Mistake number 2, letting "I need a doctor's order" be the end of a sentence. It's factually correct, and it is not the answer for this family or any family. Compare it to, "You're right, I need an order for that. Let me page the provider now so we have something on board before tonight." Identical scope, identical authority, completely different outcome at midnight. Mistake number 3, reading restlessness as behavior instead of pain. In a nonverbal or late-stage dementia patient, agitation is a vital sign. Treat it like one. Mistake number 4, and this is for the leaders listening, assuming your geriatric and dementia competency is handled because it lives in onboarding. If it's a one-time module nobody has revisited while the median age of your inpatients keep climbing, that gap is exactly where events live like this one. Let's move to listener mailbag. A listener asks, "I have 6 patients and 3 of them are high acuity. How am I supposed to do any of this?" Well, it's a fair question, and I won't insult you with a poster that says be more compassionate. Here's the honest answer, and it comes from the nurses I've coached, not from me. The instinct is to triage by who's the loudest right now or what's the loudest. The nurses who make it through a bad shift intact triage by what's going on to explode in 4 hours if nobody touches it. An uncontrolled pain dementia patient is a 4-hour bomb. So is an IV site on a patient who pulls lines. So is the family that has decided you aren't listening. That family will take an hour of your shift, then your charge nurse's shift, then patient relations' entire week. Getting ahead of the predictable thing isn't extra work. It's the cheapest work available to you all night. Another listener asks, "The family is at the bedside constantly and it's making my job harder. How do I handle that?" Well, I'd challenge that premise gently. A family that's always there is usually a family that's frightened, and frightened families get easier the moment they believe you see their person. Give them a job, hold her hand during the turn, tell me when she seems off, help me at meals. A family with a role stops hovering and starts helping, and you just gained a set of hands you didn't have. So everything here we build at the RN Network lives at rnnet.org, including the free career development workbook, 39 pages to help you map where you're going, whatever stage you're in. It's free and it always will be. If this episode hits somewhere tender and you're wondering whether you're still in the right unit, the right specialty, or the right building, that workbook is a good place to start asking the question honestly. So here's your next take action step, and it's small on purpose. Pick one patient who can't advocate for themselves, nonverbal, dementia, intubated, developmentally disabled, or just nobody at the bedside. 1. On your next shift, do the 4-second things for that one patient every single time you walk in. Cover them, say their name, say what's about to happen before you touch them. See what it does to them, and then see what it does to you. I have never watched a nurse do that for a week and not feel something come back that they thought this job had taken permanently. If you're a leader, do one thing instead. Walk your unit at 9 o'clock tonight and look at the floors. So that's it for today's episode. If this one resonated with you, please be sure to like and subscribe wherever you stream your favorite content. If you know a nurse or a leader who needs to hear this letter, please share it with them. And if you're the family sitting in a hospital parking lot tonight, wondering whether you did enough, you're not being difficult. You're the only chart they've got. Keep talking. As always, I appreciate you listening today, and remember, keep showing up because nursing matters.